to you. Up to you, my friend Renzo. If you want to present, completely up to you. What do you think?
Yeah, well, I will give it a try. Yeah.
Okay, all right, let's do it. All right, Renzo, we're ready for a chief complaint, HPI, whenever you want.
Yeah. Well, this is a history of a patient of 66-year-old woman who presents to the hospital because she has been experiencing continuous non-rhythmic involuntary movement in the right arm and leg for the past week. The patient refers that the movements have become so severe that she cannot perform her normal daily activities. Nevertheless, the movement stops while she's sleeping.
Wow, incredible start. So we hear that this is a 66-year-old woman who's having continuous involuntary movements in the right arm and leg. Is that right?
Yeah, that's right.
That recede with sleep. Amr, can you unmute and tell us more about your thinking and what prompted your question?
I thought it was just the arm, so I was thinking about maybe some side effects from antipsychotics or sorts. But if it's both the arm and the leg, then I'm thinking more of a central nervous system issue, so perhaps not as relevant.
Beautiful. No, I think, and if let's just practice. So say if it was the arm, what kinds of things would you be invoking?
Well, it could still be, I mean, I would still want to be systematic and think about the whole pathway leading to the arm, starting from it's the left arm, so our right arm, so some cortical process, then some process going on in the pathways, going down, then maybe a spinal process, finally ending at some peripheral nerve issue. And from the acuity of the situation, I would be thinking this is less likely to be a degenerative process or an autoimmune. Well, it could be an autoimmune, but I would be thinking something more acute, like a medication side effect or an infection or a trauma or a structural issue.
Amazing. That's absolutely superb. Brilliant. I have nothing to add to that. And where are you these days, by the way, Amr? I forgot to ask.
I live with my family in Sharjah in the United Arab Emirates.
Oh, wonderful.
People know it as the thing next to Dubai.
No, I actually lived there for a whole year. I know it is Sharjah, I promise you.
Yeah, okay, nice. Yeah, I'm currently applying for clinical attachments in the UK and jobs.
Yeah, fingers crossed. It's so nice to have you here again.
Thank
I saw that Jasimran is getting specific about not what the cause is, but what the kind of movement is. Jasimran, do you have the ability to unmute and tell us more?
Yes, sure. Hello, everyone. So I would we used to read this when we were preparing for the STEP exams, that there are different kinds of movement involved. Tremors, chorea, dystonia, myoclonus, these are the movement that we can interpret. So all these movements are different and they signify the different disease. So let's take off example of chorea. So in that moment, the contraction, it starts from one muscle and then it keep on progressing to the subsequent next muscle. And it feels like a dance-like movement. And that signifies that the patient has Huntington's chorea. So we look for the family history. Similarly, myoclonus, which are just sudden brief movements, and we look for myoclonic. We have there is one disease, dystrophic disease, in which we have the myoclonic movements. Similarly, tremors are there, tics are there, and like these kinds of movements. So what was the kind of a movement, how it presented, and dystonias are there, which can present as blepharospasm. In tetanus, the lockjaw, it is a kind of a dystonia, something like the torticollis. So what was the kind of a movement on physical examination is important as well.
100%. Absolutely amazing. That was poetic. I'll come to our neuro expert in the house, our actual scribe, Shema. Shema, what do you think? Do you think this is myoclonus, chorea? What is your instinct on this?
So I remember the great VMR we had with Aaron when we were talking about myoclonus. These are also involuntary movements, but I learned that these are across of joints. These are rapid movements. And coming to dystonia, I always think of these are these twisted movements that we have, and more distal, I would say. And now here the movements here are stopped while she's sleeping. Like the first things that I was thinking of something like a restless leg syndrome, especially in a very old woman, which is very typical. I mean, for restless leg syndrome, we consider things like, I don't know, iron deficiency or renal problems. So there's a lot of secondary problems that here, these movements stop while she's sleeping. So I can just say something is off and I don't know what, something quoting Drew.
100%. I think that's absolutely super. I never forgot that VMR with Aaron. I think that you played a pivotal role in it, which is why I picked on you right now. And it's a shame Nalayan mentioned earlier he can't unmute because his parents are sleeping close by, but he has some great thoughts that I'll share out loud, which is he was really intrigued by how unilateral the case is, and also mentioned specifically clumsy hand syndrome from a thalamic stroke, which I think is awesome. Hans has a really nice pearl about why this is very likely to be upper central nervous system in origin. Hans, do you want to tell us what you wrote in the chat about inhibitory effect? It's really interesting.
Yeah, but that was something that was mentioned before. When it was involuntary, I was just thinking the upper motor neurons usually have an inhibitory effect, which we can see with hyperreflexa and maybe some uncontrolled movements as well, which make it impossible to do anything voluntary, as mentioned by the patient. For voluntary movements, we need our upper motor neurons to have a coordinated movement, and without those, and that could be an injury in the cortex or somewhere in the spinal column.
Beautiful, absolutely beautiful. Okay, one thing that we have been trying to do more and more on Global VMR is to arm ourselves with the immediate treatment response. So last time, if you remember, when we did a case ourselves, when we didn't have any guests, we had a patient who was dyspneic, and we talked about how important it was to address oxygenation and ventilation. So my question for you all is, can you think of any emergencies related to this scenario? Anything that you would have to do or think about in the first hour of this patient's care? Now let's take a minute just to think about that, because I think the answer is maybe one or two. Okay, so let's mute for a little bit. I'll let you think about it and put your thoughts in the chat. What emergent diseases that, and defined as, we should do something about this as soon as possible, definitely within an hour? All right, Amr, please share those thoughts. I love them.
I still, just before I go into this a little further, can we elaborate, Renzo, please, on the acuity of the case? I heard in the beginning that it was like 1 week. Is it multiple weeks? Has it been progressive, or is it like sudden onset and then continuous? Do you know this information for us?
Well, it's just 1 week history of involuntary movement that start just suddenly. I don't know if I don't have the information if this have become worse, but just 1 week of involuntary movement.
Okay, well, in that case, going back to the question about the emergent situations that we should consider, I would be thinking about vascular insults. That could be perhaps an ischemic stroke that is developing, or perhaps multiple ischemia followed by resolution, and then again, so some unstable plaque that keeps disrupting the blood supply, and then also some meningitis, though this is not very typical from what I'm hearing, so more like an encephalitis or perhaps some other well localized infection.
Yeah.
I'm trying to think of the location. As always, I think we would be safe to just check the vitals and know how fast we have to move. If the patient is stable, their blood pressure is okay, they don't have a fever, then I think we have some time to take our time, think, look at some scans.
I think that's absolutely superb. So I think, and I think that's a point that's been reiterated by Nalina and Justin. We're saying, hey, like, make sure we have the vitals. And I think part of this exercise is to challenge yourself to think about things that you may not get. And for sure, you have to be open to the past medical history saying she has metastatic lung cancer. And then you might be like, wait, did she bleed? Did she have, like data that you are automatically going to get may change the landscape. The hardest part is remembering data that you might not immediately get. And here's two things I think we should immediately get in this patient. One, finger stick glucose. Why? Two reasons. We always assume that a systemic metabolic cause causes a symmetric issue in the brain, and that's not true. Many patients with hypoglycemia will present with focal neurological findings. More characteristically, patients with hyperglycemia can present with a non-epileptic continuous motor seizure, like this may be. It's really interesting. It's called epilepsia partialis continuous, well, partial continuous epilepsy. So I think getting a finger stick in this patient is really important. Now, I'll give you another teaser. Is there another electrolyte you think would be very important to measure in this patient? This is a read my mind, but hopefully you remember it better after we try this exercise. So sodium for sure. Sodium, there we go. I think sodium, actually I didn't think of sodium. I think sodium's totally fair game. I think it's possible. I think more likely and more characteristic of a certain electrolyte to cause neuronal hyperactivity. Sodium usually causes neuronal depression, except seizures. Patients are a little bit more confused, more sleepy, more lethargic, and then they seize. But I think hypocalcemia is really important here. So I think we're going to do our usual, get the medical history, do the exam, do the labs, probably get brain imaging. But in this patient, I would very likely get a finger stick glucose and then get an EKG. Not because I can get a calcium quickly, but hypothetically, if this patient shows up with these complaints and I have to wait 1 hour for the lab calcium to come back and the QTC is 650, you know what I'm going to do? I'm going to give calcium because it could rapidly degenerate. So when you see this, we're going to put our diagnostic hats on, but I would say get a finger stick and get an EKG, with the EKG being your fast insight into the possibility of significant hypocalcemia affecting the brain and maybe then also affecting the heart. Okay. All right, Renzo, you have us at the edge of our seats. Where is this going? Mic to you, my friend.
So the past medical history includes type 2 diabetes mellitus, uncontrolled, hypertension, hyperlipidemia, and schizophrenia. 3 months ago, she was hospitalized for an episode of hypersmolar hyperglycemic non-ketotic syndrome due to medication non-compliance. Also, the family history is not contributory, the social history is not contributory, and her health-related behaviors are not contributory.
Renzo, can I ask you, is this your first time presenting?
Yeah, it's the first time, but I have participated in other meetings. So
yeah, I'm just so impressed. You're presenting like an expert. You know when to say non-contributory. The medical history is so clear. Thank you. You clearly have picked up a lot of pearls along the way. Can I ask you where along in your training are you?
I'm a sixth-year medical student here in Peru.
Amazing. And what are you thinking of doing? What specialty?
Internal medicine.
Yes, the only correct one. I'm kidding. Everyone's welcome. We love them all. And what do you like to do for fun?
Well, I like to play the guitar.
Nice.
And also like to listen to music. My favorite band is the Guns N' Roses.
Nice.
Yeah, the first time that I joined to these meetings, I think that Jack asked me the same question. Yep.
Yeah, and no, I model my entire life after Jack Penner. So if you hear any similarity in me, it's because I'm just literally trying to copy him. I don't know. I don't know if I'm trying to spot the famous Jack Penner blush. I think I see it, but I can't tell. Yeah, that's awesome. You know, the only thing that I will push you to do that Jack may not, because he's too kind, is maybe next time we can actually hear you play the guitar. All right, give Renzo a thumbs up if you want him to play the guitar next time. Little peer pressure. All right, Renzo. Well, thank you for this really, really interesting really, really interesting background. I was so distracted by hanging out with you that I didn't see any pros in the chat. But I'm looking at them now, and folks are picking up on meds. That was the first question that Amr asked, and now it's coming in the spotlight again. Is she taking any meds, Renzo?
Currently, she's not taking her antipsychotics, and well, she's not now. Just she's taking losartan for the hypertension, and that's the only med that she's
Only
taking.
medication. Incredible. Renzo, there's a message for you from Jack in the chat where he listened to patients again this morning. Look at that coincidence. Okay, so we should practice. And let me tell you what I would suggest we practice, because there's something really unusual here. You know how often it is for a patient with schizophrenia to survive in their 60s? Very rare. I'm curious, Renzo, what is it like in Peru for patients with schizophrenia? Can you enlighten us on medical care, social stigma? What is it like for patients with this mental illness in Peru?
Well, here in Peru, we have, well, in the 90s, more or less, it was common that we admit patients in one hospital called El Arco Herrera. But now it's kind of, they get admitted for years, but now it's not that common. Now we kind of encourage patients to stay with their family. And I don't know the survival here in Peru. I mean, how many years they survive, but I don't have that data.
Yeah, that's super informative. Thank you for that cultural history. I'm curious, Amr, if you have, I'm just trying to get a sense of if my bias is a US bias. I know you were in Europe for your medical school. What was your sort of personal experience in patients with schizophrenia? How long do they live? What would you see them for? Just give us a sense of what it's like in other parts of the world.
I actually saw quite a few patients with schizophrenia during my medical studies. It's one of the, I would say, most mind-opening diseases I've encountered. We saw quite a lot. I think the vast majority, one of the most important messages that I learned about schizophrenia that our teachers kind of wanted us to keep in mind is that when let's say the common person, or even I would say medical students, when they first hear of schizophrenia, their instinct, let's say, is to think of someone who could harm others, who could be dangerous, a serial killer, or these scary thoughts, movie-related biases. But the actual the facts are that they are actually very susceptible to being harmed, that they are, even though they make up 1% of the population, generally they are 10% of the homeless population. So a patient with schizophrenia is actually at a high risk of being abused, even as an adult, being abused even by someone you might think of them being physically weaker than them, whether that being before they are receiving medications or after receiving medications. So my first instinct when I think of someone with schizophrenia is that it's a vulnerable population that often needs protection, and people need to know that and not fear them as much as people do usually.
Amr, that was inspirational. That was so well said. Really, thank you so much for saying that. And the lion captured it also. He said, similar to you, he said, schizophrenia has an unfortunate association with high suicide rates, and the high homicidal rates are mostly a myth, which I think is beautiful. And I appreciate you guys setting light on that and giving us a global perspective of what it's like. Okay, I'm going to come to my friends to do another practice. You have diabetes and you have neuro, right? What complications of diabetes do you think, in general, not in this patient? So what are the general neurological complications of diabetes? And while you do that, I'll pull up a schema. So let's get it in the chat and see what we can get together, okay? So neuro plus diabetes, what do we get? All right, Justin, tell us what you have.
Oh, so the first thing that comes to my mind is the like sensory neuropathy, because we see so many patients with diabetic foot ulcers because they lose their peripheral senses. So it's like sock and glove patterns. So they start losing from the periphery. So they present that they have multiple injuries on the foot specifically, or sometimes while working and they don't have idea about it. So that is one thing that comes to my mind. And second comes the autonomic neuropathy. And I have seen like the gastroparesis in patients who have autonomic neuropathy. So that two things that come to my mind regarding the diabetes and neurological disorders. So these were the two.
Absolutely superb, my friend. I have to come into our neuro CP Solvers team member in residence. Shema, what do you think? With diabetes plus neuro, what else is on your short list?
Oh my gosh. I mean, I actually had the same thoughts, but I was also considering unspecific symptoms, like if diabetic people have something like a myocardial infarction that were typically silent due to the neuropathy. But yeah, otherwise I would need a little bit more help, because these are also the things that are coming to me.
Yeah, no, I love it. Beautiful. You know, the reason these things are coming to us much quicker is because they are much more common and very, very common. So it's hard to remove them because how much they weigh. You ready? This world is very complicated. And I think there's one thing here that we should entertain. One thing specifically related to diabetes we should entertain. So it's helpful to divide the diabetic neurocomplications into CNS and peripheral nervous system. Let's start with the peripheral nervous system. If I could have your eye go to the most common mentioned by everybody, highlighted by Justin Braun, is polyneuropathy plus minus autonomic symptoms. And as Nalayan highlighted in the chat, the autonomic systems can extend to the bladder, most commonly causing neurogenic bladder, but can also cause constipation and orthostatic disease. The rare manifestations are fascinating and really are all infarctions. Shema reminded us of how vascular diabetes is with mentioning myocardial infarctions, but the truth is you can infarct many things. The most common infarction is a cranial nerve infarction, cranial nerve 3 causing diplopia. And believe it or not, you can infarct all these other places, the phrenic nerve causing dyspnea and orthopnea, the thoracic nerve roots exiting causing a thoracic radiculopathy. You can infarct the lumbosacral plexus, and you can infarct so much you have a vasculitic-like presentation. Mononeuropathy multiplex. Look at how long this list is. You can also infarct the muscle. This is important to know. This is not super rare. It's not common, but it's not super rare. And classically presents as severe pain and weakness, usually in the lower extremities and often in the thighs. And so if you have a patient who has diabetes who has really bad thigh pain, you should definitely consider this diagnosis, and it would be supported by getting a CK. So why could we not move past stroke, glucose, and polyneuropathy? They're so common. But in cases where you don't, the cases we have here isn't fully lining up classically, at least with one of these things, which is why these schemas are helpful. They're helpful, nobody can remember all this, nobody can, but helpful to refer to them in this case. So what are the rare CNS manifestations? They almost always occur in non-ketotic hyperglycemia. Why? It's really interesting. Ketones suppress epileptic activity. A ketogenic diet has been associated with reduced seizure frequency in patients with refractory seizures. So these complications are relatively unique to people who have non-ketotic hyperglycemia. It's really interesting. The sugar level doesn't correlate with the sugar level has to be high, usually over 300, but the degree of hyperglycemia doesn't correlate with the presence of these symptoms. They just happen in a subset of people with diabetes who have non-ketotic hyperglycemia. And overt frank seizure is one of them. Epilepsia partialis continua, which we mentioned earlier, is a very good description of what's happening to this patient right now. As is diabetic striatopathy, only differentiated by the fact that diabetic striatopathy shows up on MRI and is usually associated with more choreiform movements. And you can actually also get occipital lobe seizures presenting as visual hallucinations in patients with non-ketotic hyperglycemia. So to recap, what's our overlap between diabetes and neuro? Let's just stay rooted in the common stuff. Centrally, it's strokes, and the glucose complications. Peripherally, it's a neuropathy, symmetric with autonomic symptoms, but now you know there are very rare things. The rare things in the peripheral nervous system all have to do with diabetes causing infarction. The rare things in the central nervous system all have to do with non-ketotic hyperglycemia and its pro-stimulatory activity. So in this patient, we go back to what we started with. We need to get a rapid analysis of this patient's glucose. And we have to be open to both high and low being a problem. And here, because of the specific manifestations, I'd be more expecting a high glucose rather than a low one. Before we move on, any questions about that from anybody? Feel free to unmute or say something in the chat.
I have a question about the epilepsia partialis continua.
Yeah.
Is it due to an infarct, or is it due to the current glucose level?
It is due to, so thankfully there is, my understanding of this condition is not at a level where I would, what I'm telling you, I would be confident about in clinically. I would kind of have the same confidence like answering a test question. Like I'm moderately confident that I would get it right, but not 100% sure. But here's what I know. Epilepsia partialis continua is a non-ischemic seizure focus. So it really is focal motor seizures, usually from a metabolic issue and usually from the glucose level. So you don't have to worry about a stroke in that condition as far as I know.
And is it usually that the glucose is too high or too low?
Too high.
Too high, you would say, yeah. Okay.
Correct. All those conditions that we just talked about are all from patients who have high glucose, high, non-ketotic hyperglycemia. Beautiful. Yeah, you know, Nilan, I don't know. I don't know. Actually, that's a big gap in my knowledge. It would, the seizure and sleep has always been complicated for me. I think I know that when patients don't sleep well, their seizure threshold goes high. They are more prone to have seizures. I don't know if true sleep can suppress that seizure activity. I have no idea. I don't know if we can look that up, or I can look it up. I'll read about it for sure afterwards. But that'll be maybe something that if it's relevant to this case, our friend Renzo can teach us. If not, we'll have to learn it later. Any other questions, folks? All right, Renzo, let's hear from you, my friend.
Yeah, so now the vitals are stable. Well, in the physical examination, the neuro exam shows that there is right upper and lower extremity hemivalism and hemichorea-like movements. The finger nose maneuver was normal on the left side, but showed severe dysmetria on the right side. The pupils were normal. The cranial nerve examination wasn't remarkable. No motor or sensory deficits. And the other part or the other components of the exams were normal.
Amazing. What do you all think? Chorea-like movement, a really good opportunity for us to practice what we think can cause chorea. So I'll mute for about 30 seconds or so, or a minute maybe, to see what thoughts accumulate. Let's just practice our general differential for chorea, and then we'll take that general differential and try to apply it to this patient. Okay, so keep the thoughts coming. Hans, teach us. I love your differential.
Yeah, but I don't know much about chorea, so I'm a learner here. But I
Right.
remember that rheumatic heart disease in one of the more severe stages is causing chorea. Now, I don't know exactly the pathophysiology that goes into it. So now I need to learn from others.
Oh my Hans, you know, the reason I love hearing your voice is because I think you most model how open you are about the fact that we're all learners. You know, I'll just be honest with everybody here and watching on YouTube. Every single VMR that I do facilitate prompts me to read for at least an hour or two afterwards. So just because I'm the one who is in the facilitator teacher position doesn't mean that I'm not a learner. I learned so much from hanging out with you guys, and at least an hour after every VMR, which sounds crazy, but it's true. So yeah, I don't know much about it either. I just know it can happen. And I don't know the pathophysiology either. Seema, the neuro brain is firing. Tell us more.
What I remember, like we also have these neuroacanthosis syndromes where we have chorea-like movements. And if you look at into the blood smear, we see these acanthocytes. And that's also something what I remember from Kirtan, especially McLeod. This results from, I think it was something in the KEL system. That's what I only remember because he told me you have to be very careful if you give these people transfusions, because we can develop some hypersensitivity reactions, because I think there was something like KEL deficiency. Yeah.
Absolutely superb. I love that. Okay, I'm going to give you some guidance. What if somebody has a family history of chorea and all of those patients developed dementia? What do they have? Huntington's. Mohammed, can you tell us more? What do you know about it?
Don't know much. It's about it's a family autosomal dominant inheritance.
Beautiful.
With patients about 40 years old who develop firstly some chorea-like movements and progresses up to dementia.
Incredible. If that's your definition of not much, I'm really worried about the things you know. You know, Muhammad, I'm from Lebanon and I'm missing my hometown food a lot. So I wanna live through you. What did you have for dinner today?
Oh, I had some we call them wara ainab, which is grape leaves.
Oh, of course, man. Of course.
With some rice in it.
Yes.
It's beautiful.
Oh, my
actually, it's actually very, very popular in Lebanon and Syria, neighboring countries.
Yes, no, I had a lot in Lebanon. It literally, for all those of you, wara ainab literally translates for the like paper of grapes. So it's rice and sometimes meat wrapped in dried grape leaves, and it's unreal. Do you guys have it with lemon or not so much lemon, or?
No, too much lemon.
Yeah, right. Too much lemon. Yeah, 100%. Well, thank you so much for sharing that. You know, chorea simply comes down to there's pathology in the deep brain matter, be it the lobus pallidus, the thalamus. And so the question really in real life is it radiographically positive? Can I see something on CT, or are there any other clues? The other big genetic thing to know about that causes, that's the other big thing that's important for an internist to know about is Wilson's disease. So as Amr just said, perfect timing. So when I ask myself, hey, this patient has chorea, what do I need to know? I try to keep track of Huntington's, try to keep track of Wilson's, try to respect the fact that a stroke in that region can also present with chorea. And then I try to remember the metabolic causes. And the metabolic causes are HHS, as we've talked about. Hyperthyroidism can result in a chorea, and pregnancy-related chorea is really important to keep track of. So what does an internist remember? Huntington's gets the headlines. Wilson's is a really important thought. The three metabolic causes: sugar, thyroid, and pregnancy. And then most importantly, to recognize the possibility of a stroke presenting this way. I'm just going through the chat, and I think we've mentioned, and Alex, thank you so much for mentioning that. I didn't, do you know more about the imaging findings in Huntington's? I didn't know that it was a caudate thing. Tell us more. If you can, I see you're outside. Yeah, go ahead.
I'm not sure there's an actual imaging finding associated with it. I just know that's where the lesions are, but imaging I'd have to look up a little bit more.
Gotcha. Awesome. Thank you so much. By the way, where are you hanging out?
I'm just at home. I'm in New York. I'm outside.
That's awesome. Wait, what's it like in New York right now? What's the weather like?
It's like 60. So
that's not bad.
Barely able to. Yeah.
It is the midday though. Well, no, it's like almost 4. Never mind.
Like 4. 3:45.
The sun's bidding you farewell soon. Awesome. Well, thanks for hanging out.
Sure.
I see Seema's going in the deep end with piquant iron accumulation. Yeah. Tell us more.
They have this iron accumulation. I think it was where the basal ganglia are, and I always remember the spot diagnosis of the eye of a tiger sign. That's why I
Ooh.
was also considering it.
Amazing. Anything that has the eye of tiger, you should probably know it. For the fun of it. Amazing. All right, Renzo, we'll give you the mic to tell us more.
The lab shows a Y blood count of 6.42. The hemoglobin is 10.1. The platelet count is 231. The sodium is 136. The chloride is 112. The blood urine nitrogen is 43. The creatinine is 1.69. The calcium is 8.8, and the liver enzymes shows AST of 16 and ALT of 19. The alpha phosphate is 66. The total proteins is 6.6. The albumin is 3.4, and the glucose is 298, and the hemoglobin A1C is 12.
All right, y'all, what do you think? We only have 5 minutes before we reflect, so I would love for y'all to try to see what I'll repeat it for you, Shema. I think the final piece of data was hemoglobin A1C is 12. I think Renzo's kind enough to put it in the chat. All righty. You know, there are people here who haven't been able to participate. So if you are able to type in the chat, if not, no worries. What do you all think is going on? Utter silence. People are intrigued by this.
If I can, I don't know, speak.
Yeah,
I would say that the question now is, do you get further brain imaging or not? And as a coward myself, I would say definitely yes.
Well, you know, I don't know if I would agree with that. I would never call you a coward. But I think that Renzo literally, as soon as you said that, says, I have an image to show. So I think that reality supports your assessment. All right, Renzo.
Yeah.
Yeah, go ahead. Go ahead, Amr. Please finish. Sorry.
I think like at this stage we could again discuss further, but in real life I think we would not rush to any diagnosis without getting imaging at this stage. We have to see if there's any positive imaging finding or any negative findings and then differentiate.
Absolutely superb. I love that. Very practical. You have, you know, this is a patient with diabetes. We haven't ruled out a structural lesion or a stroke, so I think that's very important. Alrighty, Renzo, the mic is yours, and I made you co-host, so hopefully you should be able to share.
Yeah, I will share an image. First, a CT scan just shows my global cortical hypertrophy, but no evidence of any acute intracranial pathology. And they took an MRI that I can show.
Please.
Can you see my?
Yes.
Yeah, and this is the finding.
100%. Beautiful. All right. Anyone want to take a guess what that is? All right.
Can I again?
Yeah.
I wouldn't be able to specify like without scrolling through it, but I mean, it's definitely in the basal ganglia. The thing is, it's on the left. Would that be the right spot for our lesion, or would that just be perhaps some, you know, unrelated finding? I wouldn't be very sure about that.
It's always a good thing to cross-check and slow down, but it is contralateral to your finding, which is, you know, the findings for the patient were on the right side, so a left-sided lesion makes a lot of sense.
I think. Yeah. Sorry, I think he said this is a left-sided finding, and the patient has left-sided chorea. If I'm correct, no?
Oh, I thought it was right-sided, but I may be wrong. We'll see on the board. I thought the chorea was on the right side. Yeah, I'm getting
it's
the
not
ones.
right.
Yeah, it's the right side. Is the right, both the right side and the correct side for this lesion. Alex, tell us more.
Not too much to add. I agree that it looks like it's in the basal ganglia. A little weird that it's on the left-hand side. It's like a little bit hyper intense, I guess. I don't know if that's probably not suggestive of ischemia would be my guess. It looks like this is T1 with contrast. I don't know, not too much more.
No, I think you nailed it. I think that this does not look like ischemic, and it totally maps onto the gray matter territory of what I think is the putamen, but I'm not sure either. And I think based on the fact that there is no lesion, and the fact that there's no mass lesion, and this is not in a vascular territory, I think you can move away from our hypotheses. And maybe prompted by the fact that on the far right of Lorenzo's tab is chorea, hyperglycemia, basal ganglia. I think, by the way, I'll tell you, there was one time when Reza and I were doing like this really hard CPS. It was at this like fancy grand round. And the presenter opens up the PowerPoint, and the title of the PowerPoint is sarcoidosis and the date. And I was like, oh man, like what are you supposed to do now? Do you tell them that you know the answer? What if it's not the answer? Are they messing with you? How can you discuss authentically when you know the answer at the end? So if you're ever in a situation where you're doing a high stakes case, don't put the title in the slide. Don't ever do it. Anyway, Renzo, back to you to tell us what happened in this case and what you learned from it and how you treated the patient.
Well, in the end, the final diagnosis was I have the follow-up, and the final diagnosis was hemichorea mevalism non-ketotic hyperglycemia. And what I learned from this case is that this patient did not show hyperglycemia, but this is something that I learned because I attend to one conference in which they discuss one similar case. And one of the differential diagnoses that you have to take into account when facing a patient with diabetes, and also he has a past medical history that he has been admitted because of hypersmolar diabetes, non-ketotic crisis. You have to take into account that some movement, some complication in the central nervous system can appear, such as hemichorea, as you have shown in your in the PowerPoint that you show us. And that's why I learned that one differential diagnosis in the patient with diabetes that develops chorea, you can think about that the basal ganglia could be affected, and this is something that is specific of this condition.
I think that's absolutely superb, my friend. Absolutely superb. And I think it's fitting now that maybe you can try to give us your problem representation, but in Spanish.
I if that, bueno, es un paciente de 66 años con antecedentes de diabetes, dislipidemia, hipertensión y esquizofrenia, que se presenta con movimientos no rítmicos de una semana, tanto en la mano derecha como en la mano izquierda, y con antecedentes de haber sido hospitalizada por una crisis hiperosmolar secundaria a diabetes, ¿no? El examen físico mostró lo que es corea, movimientos tipo corea y también hemivalismo.
Amazing. I understood like 70% of that. That was really cool. I feel like I'm learning Spanish while learning medicine on Global VMR. That was a treat. And how did she do with how did you treat her and how did she do?
The thing that is interesting is that with the patient start with insulin, and the glucose level start to control, and 3 months after the admission, she was the movement it kind of disappear. And this is not one case that it's something that I have read about, and I also look for a case report. It's not one patient that I have faced, but this is something that I learned in a conference, as I said, and this is something that I think that could be interesting to think about.
For sure. I am so grateful for you for presenting this case. I've learned so much from it, and learned about the case itself, but also about schizophrenia and how that is globally, and learned how to think about this acutely, and learned about the imaging findings, which I didn't know. And we got to practice the core schema here is diabetes plus neuro, right? And I think practicing that was a real treat. Okay. We hope you guys had a good time. And I hope this new time isn't too much of a stretch, but if Nalayan can show up here at 2 a.m. with his parents next door sleeping, I think that is the gold standard that we all strive and aim for. And Mohammed, I hope you enjoy grape leaves for the rest of your week. And I'll pass the mic to Marcella to summarize the teaching points.
Hi, everyone. Oh, thank you so much for the case. It was an amazing case, helping us with our neurophobia, right? So first we started, we localized the lesion probably in the CNS. And always when we think about neuro, we think about localization and time. And here we had like a acute, subacute course. And in this case, we always should consider if it's an emergency, what should we do? So we could get a finger stick glucose that could show hypoglycemia or hyperglycemia. And Javi taught us today how much it's important. And in the end, we saw that it would help with the final diagnosis. And then an AKG, because it can show kidney prolongation, it's a clue for hypocalcemia, and it's faster than the lab could show you. And hypocalcemia can lead to neuronal hyperactivity, and we can see the Chebyshev sign, the Trousseau sign that we can do in the physical exam. And we also thought about hyponatremia, but usually hyponatremia will lead to a neuronal hypoactivity. It's the opposite. And we saw how important it's to describe the type of movement. So, for example, is it a myoclonus, a chorea, like here? And we saw that it's one muscle moving and another one, like a dance, or dystonias, or other type of movements in neuro. Then Shema told us about Tesla's leg syndrome. It's the urge to move the legs. It can happen in a lot of cases, but maybe iron deficiency, uremia. And we saw that this patient had schizophrenia. So we were thinking, patients with schizophrenia, they have higher morbidity and mortality. So you should definitely consider the social determinants of health of the patient, because it can change a lot your diagnosis and also your treatment. And note that those patients, they don't have the same access to healthcare. They also will be leading to stigma and other aspects. And then we saw diabetes. Diabetes, it's a highly prevalent disease, and it has a lot of neurological complications. So in the CNS, you can think about stroke, hypoglycemia or HHS. It can lead to seizure, epilepsia partialis continua, diabetic striatopathy, and occipital seizure that the patient is going to present with visual hallucination. And the peripheral nervous system, it's common, so you can have PNP. In hair, you can have like mononeuritis multiplex, phrenic nerve palsy, and autonomic neuropathy. For example, gastroparesis, neurologic bladder. And in the muscle, we saw that the patient could present with diabetic muscle infarction. And Chem also told us something really important, that patients with diabetes, they can have a silent myocardial infarction. So always consider that. And some things about epilepsia partialis continua. It's a non-ischemic seizure, focal, and triggered by a known cathodic hyperglycemia. So and a pair of knowledge that ketones suppress epileptic activity. So think about that. You are not considering this diagnosis when you have high ketones. People can use high ketone diet to suppress epilepsy. And then we saw that the patient had really chorea-like movements in the physical exam. So it's usually something affecting the deep brain, like we saw here in the image. It can be like the globus pallidus, thalamus, and some differential diagnoses. It's chorea, Huntington, chorea minor, like Sydenham, in rheumatic fever, acanthocytosis, and Wilson disease, stroke, or some metabolic causes like HHS, hyperthyroidism, or it can be related to pregnancy or PKANT. You can see an eye of tiger sign and iron accumulation in the basal ganglia. And that's all for today. Thank you so much.
Oh, absolutely superb. You summarized the wisdom from so many different people and added your own. That was awesome. Thank you all so much. And we'll see you next time. Bye.